Thiamine, also known as vitamin B1, is an important vitamin that is commonly tested in the context of beriberi. Beriberi can manifest in two forms: wet beriberi and dry beriberi. Wet beriberi involves high-output heart failure, where the heart becomes dilated and cardiac output is increased. Dry beriberi, on the other hand, typically involves damaged nerves and muscle atrophy throughout the body. Another high-yield topic related to thiamine deficiency is Wernicke-Korsakoff syndrome. This can be remembered using the mnemonic CAN-O-BEAR, where the letters stand for confusion, ataxia, nystagmus, and ophthalmoplegia. Alcoholism is a key risk factor for thiamine deficiency, which can lead to this syndrome. Korsakoff syndrome is characterized by confabulation, where patients fill in gaps in their memory with fabricated details. Niacin, or vitamin B3, deficiency can lead to a condition called pellagra, also known as the 3Ds: dermatitis, diarrhea, and dementia. The characteristic skin rash has a necklace distribution. Niacin is also important for its role as a component of the molecules NAD+ and NADP+, which are involved in energy production through glycolysis and the TCA cycle. Folate, or vitamin B9, plays a crucial role in pregnancy, as it is necessary for neural tube closure in embryos and fetuses. A folate deficiency can lead to a macrocytic anemia, where the red blood cells have an MCV over 100 FL and have more than 6 lobes. To diagnose a folate deficiency, you would check elevated homocysteine levels, while methylmalonic acid levels would be normal. Folate is primarily absorbed in the jejunum and is involved in important methylation reactions and the synthesis of nitrogenous bases. It is found in leafy green vegetables, and supplementation is recommended during pregnancy to prevent neural tube defects. Folate deficiency can present similarly to a vitamin B12 deficiency, as both can lead to a megaloblastic anemia. However, a B12 deficiency is characterized by subacute combined degeneration, with symptoms like weakness, tingling, and numbness in the extremities. Lab findings would show elevated homocysteine and methylmalonic acid levels in a B12 deficiency. Cobalamin, or vitamin B12, is another high-yield vitamin. A B12 deficiency can lead to subacute combined degeneration, characterized by symptoms like weakness, tingling, and numbness in the extremities, as well as clumsiness and loss of proprioception. Unlike a folate deficiency, a B12 deficiency will show elevated levels of both homocysteine and methylmalonic acid on lab tests. Vitamin B12 is primarily found in animal products, and it can be stored in the liver for years, so deficiency is relatively rare due to dietary causes. One of the ways a B12 deficiency can manifest is through pernicious anemia, where the patient develops antibodies against intrinsic factor, reducing B12 absorption. Vitamin C, also known as ascorbic acid, plays a crucial role in the production and stabilization of collagen. A deficiency in vitamin C can lead to scurvy, which can present with corkscrew hairs, easy bruising and bleeding into joint spaces. The tea and toast diet, common in the elderly, can lead to vitamin C deficiency, as citrus fruits and other vitamin C-rich foods are lacking. Vitamin C deficiency can be mistaken for hemophilia due to the bleeding symptoms. Retinol, or vitamin A, is essential for normal vision, as it is a component of the opsins in the eye. Vitamin A deficiency can lead to night blindness, dry and scaly skin, and Beto spots on the eye. Interestingly, a specific form of vitamin A, all-trans-retinoic acid, ATRA, is used to treat a type of leukemia called acute promyelocytic leukemia, APL. Vitamin D is crucial for calcium homeostasis. It exists in two main forms, D2, ergocalciferol, and D3, cholecalciferol. Vitamin D must be activated in the kidneys to its 1.25 OH2D3 form before it can exert its effects. A deficiency of vitamin D in children can lead to rickets, while in adults, it can cause osteomalacia. Elevated parathyroid hormone, decreased calcium, or decreased phosphate levels will all stimulate the activation of vitamin D to increase calcium absorption. Vitamin E, or tocopherol, functions primarily as an antioxidant. A deficiency can lead to a hemolytic anemia, along with a subacute combined degeneration-like presentation, differentiating it from a pure B12 deficiency. Vitamin K plays a vital role in blood clotting, as it is necessary for the gamma carboxylation of factors 2, 7, 9, and X. Warfarin inhibits the enzyme epoxide reductase, which activates vitamin K, thereby reducing clotting factors. Newborns require a vitamin K injection, as they lack the intestinal flora to synthesize it. Vitamin K is also one of the fat-soluble vitamins, along with A, D, and E, which are absorbed differently than the water-soluble vitamins. Essential fructosemia is a relatively mild condition caused by a defect in the enzyme fructokinase. Without this enzyme, fructose can freely enter and exit cells, leading to the presence of fructose in the urine. However, this condition is generally benign and asymptomatic. In contrast, hereditary fructose intolerance is a more severe disorder caused by a deficiency in the enzyme aldolase B. This enzyme normally converts fructose 1-phosphate into dihydroxyacetone phosphate and glyceraldehyde. With the deficiency, fructose 1-phosphate accumulates within cells, depleting available phosphate. This disruption of glycogenolysis and gluconeogenesis can lead to symptoms like hypoglycemia, jaundice, and vomiting when the patient consumes fructose-containing foods. The main treatment is to avoid fructose and other sugars that can be broken down into fructose, such as sucrose. The key difference between these two conditions is the severity of the symptoms. Essential fructosemia is generally asymptomatic, while hereditary fructose intolerance can be quite severe, requiring dietary changes to manage the condition. Galactokinase deficiency is a milder form of galactose metabolism disorder. In this condition, the enzyme responsible for converting galactose to galactose 1-phosphate is deficient, leading to the accumulation of galactose in the blood and urine. The main symptoms associated with galactokinase deficiency include cataracts in the eyes and an inability to track objects, as well as a delay in developing social smiles. While these symptoms are present, the overall condition is less severe compared to classic galactosemia. Classic galactosemia is caused by a deficiency in the enzyme galactose 1-phosphate uridyl transferase. When infants with this condition begin consuming galactose-containing foods, such as breast milk, they can develop symptoms like cataracts, an enlarged liver, jaundice, and failure to thrive. One of the common infections seen in neonates with classic galactosemia is E. coli sepsis. The primary treatment for both forms of galactose metabolism disorders is to eliminate galactose and lactose from the patient's diet to prevent the accumulation of harmful metabolites. Von Gierke disease, or type 1 glycogen storage disease, is caused by a deficiency in the enzyme glucose 6-phosphatase. This leads to an accumulation of glycogen and glucose 6-phosphate in the liver and kidneys, resulting in hepatomegaly, hypoglycemia, and lactic acidosis. Patients with von Gierke disease often present with a characteristic doll-like face eyes due to the accumulation of fat in the cheeks. They may also experience growth retardation, delayed puberty, and an increased risk of gout due to the overproduction of uric acid. Pompe disease, or type 2 glycogen storage disease, is caused by a deficiency in the lysosomal enzyme alpha-glucosidase. This leads to the accumulation of glycogen in the lysosomes, particularly in cardiac and skeletal muscle. The infantile onset form is characterized by severe cardiomegaly, hypotonia, and death within the first year of life. Cori disease, or type 3 glycogen storage disease, is caused by a deficiency in the debranching enzyme amylo-1,6 glucosidase. This results in the accumulation of limit dextrin, a branched form of glycogen, in the liver and muscles. Patients may present with hepatomegaly, hypoglycemia, and muscle weakness. In contrast, McArdle disease, or type 5 glycogen storage disease, is caused by a deficiency in the muscle-specific isoform of glycogen phosphorylase. This leads to an inability to break down glycogen in the muscles, resulting in exercise intolerance, muscle cramps, and myoglobinuria, dark urine, after strenuous activity. The key distinguishing feature of McArdle disease is that patients typically experience an improvement in their exercise tolerance after a brief warm-up period, known as the second wind phenomenon. This is due to a shift in energy metabolism from glycolysis to fatty acid oxidation. The management of glycogen storage diseases often involves dietary modifications, such as frequent feedings to prevent hypoglycemia, as well as enzyme replacement therapy in some cases. Early recognition and appropriate treatment are crucial to prevent long-term complications and improve the quality of life for these patients. Gaucher disease is a lysosomal storage disorder caused by a deficiency in the enzyme glucocerebrosidase. This leads to the accumulation of glucocerebroside in the lysosomes of macrophages, resulting in the characteristic Gaucher cells seen on biopsy. The three main types of Gaucher disease are type 1, non-neuronopathic, type 2, acute neuronopathic, and type 3, chronic neuronopathic. Type 1 is the most common and presents with hepatosplenomegaly, anemia, thrombocytopenia, and bone pain. Types 2 and 3 involve neurological manifestations, with type 2 being the most severe and rapidly progressive. Fabry disease is caused by a deficiency in the enzyme alpha-galactosidase A, leading to the accumulation of globotriaosylceramide, GB3, in various tissues. The classic presentation includes acroparesthesias, burning, tingling sensations in the extremities, angiokeratomas, small dark red skin lesions, and corneal opacity. As the disease progresses, patients may develop renal failure, cardiac complications, and cerebrovascular events. Enzyme replacement therapy with recombinant alpha-galactosidase A is the primary treatment for Fabry disease. Niemann-Pick disease is a group of lysosomal storage disorders caused by deficiencies in various enzymes involved in the metabolism of sphingomyelin. The most common form, Niemann-Pick type C, is characterized by the accumulation of cholesterol and other lipids in the lysosomes, leading to progressive neurological symptoms and hepatosplenomegaly. Niemann-Pick type C is often referred to as the childhood Alzheimer's due to the similarities in the neurodegenerative process. Treatment options for Niemann-Pick disease are limited, but miglustat has shown some promise in slowing the progression of the neurological symptoms. Mucopolysaccharidosis, MPS, is a group of lysosomal storage disorders caused by deficiencies in enzymes involved in the breakdown of glycosaminoglycans, GAGs. The various types of MPS are differentiated by the specific GAG that accumulates. MPS type I, also known as Hurler syndrome, is caused by a deficiency in the enzyme alpha-L-iduronidase. This leads to the accumulation of dermatan sulfate and heparan sulfate, resulting in a wide range of symptoms, including coarse facial features, hepatosplenomegaly, and progressive cognitive and physical impairment. MPS type 2, or Hunter syndrome, is caused by a deficiency in the enzyme iduronate sulfatase. Like Hurler syndrome, it is characterized by the accumulation of dermatan sulfate and heparan sulfate. But the presentation is generally less severe, with a slower progression of symptoms. MPS type 3, or Sanfilippo syndrome, is caused by a deficiency in one of the 4 enzymes involved in the breakdown of heparan sulfate. Patients with Sanfilippo syndrome often present with severe neurological deterioration, behavioral problems, and developmental delays, with a relatively preserved physical appearance. MPS type IV, or Morquio syndrome, is caused by a deficiency in the enzymes N-acetylgalactosamine 6 sulfatase, or beta-galactosidase. This leads to the accumulation of keratan sulfate, resulting in skeletal dysplasia, short stature, and corneal clouding. The management of mucopolysaccharidosis often involves a multidisciplinary approach, including enzyme replacement therapy, hematopoietic stem cell transplantation, and supportive care. Early diagnosis and intervention are crucial to slow the progression of these debilitating disorders. Pompe disease, which was discussed earlier, is also considered a lysosomal storage disorder, but it is classified separately due to its unique pathophysiology and clinical presentation. Maple syrup urine disease, MSUD, is an inborn error of branched-chain amino acid metabolism caused by a deficiency in the enzyme complex that catalyzes the decarboxylation of leucine, isoleucine, and valine. This leads to the accumulation of these amino acids and their toxic metabolites, causing a distinctive maple syrup odor in the urine, sweat, and cerumen. Newborns with MSUD typically present with poor feeding, vomiting, lethargy, and eventually neurological symptoms like seizures and coma. If left untreated, the accumulation of branched-chain amino acids can lead to cerebral edema, brain damage, and death. The mainstay of treatment is a strict protein-restricted diet and close monitoring of amino acid levels. Phenylketonuria, PKU, is an inborn error of metabolism caused by a deficiency in the enzyme phenylalanine hydroxylase, which converts phenylalanine to tyrosine. This leads to the accumulation of phenylalanine and its metabolites, which can have neurotoxic effects, particularly in the developing brain. Infants with PKU may appear normal at birth, but if left untreated, they can develop intellectual disability, seizures, and other neurological complications. The primary treatment for PKU is a strict phenylalanine-restricted diet, which must be maintained throughout the patient's lifetime to prevent the adverse effects of phenylalanine accumulation. Homocystinuria is a group of inherited disorders characterized by the accumulation of homocysteine and its metabolites, often due to a deficiency in the enzymes involved in the metabolism of methionine. Depending on the specific enzyme defect, homocystinuria can present with a wide range of symptoms, including developmental delay, skeletal abnormalities, thromboembolism, and lens dislocation. Treatment for homocystinuria typically involves a methionine-restricted diet, supplementation with betaine or vitamin B6, and in some cases the administration of cysteine or N-acetylcysteine to help reduce homocysteine levels. Tyrosinemia is an inherited disorder caused by a deficiency in one of the enzymes involved in the metabolism of tyrosine, leading to the accumulation of toxic metabolites like fumarate lactoacetate and succinylacetone. The 3 main types of tyrosinemia, types K or RS2, and the third, have distinct clinical presentations ranging from liver and kidney failure to eye and skin problems. The management of tyrosinemia often involves a tyrosine-restricted diet, supplementation with nitisinone, an inhibitor of the enzyme that produces the toxic metabolites, and in some cases, liver transplantation for severe cases of type I tyrosinemia. Early recognition and appropriate treatment of these inborn errors of metabolism are crucial to prevent the devastating consequences and improve the quality of life for affected individuals and their families. Down syndrome, also known as trisomy 21, is the most common chromosomal abnormality in humans, caused by the presence of an extra copy of chromosome 21. Individuals with Down syndrome often display characteristic physical features such as a flat facial profile, upslanting eyes, and a protruding tongue, as well as intellectual disability and an increased risk of various medical conditions. The severity of the intellectual disability in Down syndrome can range from mild to severe, and affected individuals may also experience delayed developmental milestones, speech and language difficulties, and behavioral challenges. Early intervention, including educational and therapeutic support, can significantly improve the outcomes for individuals with Down syndrome. Fragile X syndrome is the most common inherited form of intellectual disability, caused by a mutation in the FMR1 gene located on the X chromosome. This mutation leads to the silencing of the gene, resulting in the absence or reduction of the Fragile X mental retardation protein, FMRP, which is essential for normal brain development. Individuals with Fragile X syndrome may exhibit a range of cognitive, behavioral, and physical characteristics, including intellectual disability, autism spectrum disorder, attention deficit hyperactivity disorder, ADHD, and distinctive facial features. Early diagnosis and comprehensive management, including educational and behavioral interventions, can help improve the quality of life for individuals with Fragile X syndrome. Huntington's disease is an autosomal dominant neurodegenerative disorder caused by a mutation in the Huntington, HTT gene, which leads to the production of an abnormal Huntington protein. This protein accumulates in the brain, causing progressive neurodegeneration and the development of characteristic motor, cognitive, and psychiatric symptoms. The onset of Huntington's disease typically occurs in adulthood, with symptoms gradually worsening over time. There is no cure for Huntington's disease, but various treatments, including medications and supportive therapies, can help manage the symptoms and improve the quality of life for affected individuals and their families. These genetic abnormalities, while distinct in their underlying causes and clinical presentations, share the common challenge of requiring comprehensive, multidisciplinary care to address the diverse needs of affected individuals and their families. Early detection, genetic counseling, and access to appropriate support services are crucial in managing these complex conditions.